Good evening, everyone. Welcome to our Facebook Live event. I'm your host, Dr. Naveed Shah. I'm the CMO of Home Rehab Network, where we do online cardiac and pulmonary rehab. I'm delighted tonight to introduce to you, as part of our Ask the Expert series, Dr. Eugene Shostak. Dr. Shostak is Assistant Professor of Medicine at Weill Cornell Medical Center, where he is an interventional pulmonologist in the Department of Cardiothoracic Surgery. Dr. Shostak is board certified and an expert in interventional pulmonary, general pulmonology, as well as critical care medicine and internal medicine. In addition to lung valves, Dr. Shostak is also an expert in tracheobronchial malaise, bronchoscopy, flexible and rigid, endobronchial ultrasound, bronchial thermoplasty, and many other procedures. He's won many awards, including the Castle Connolly Top Doctor Award for 2023. And I'm proud to introduce Dr. Shostak. The way we're going to be doing this, he will give a short, brief introduction about lung valves, and then we'll have a question-answer session afterwards. Thank you, Dr. Shostak. Go ahead.
Thank you so much. Thank you, Dr. Shah, and thank you for the network for organizing this and for the invitation. I'm going to go ahead and share a couple of slides, which will be hopefully helpful in providing some background information on what is COPD, what is chronic obstructive lung disease, and what are these valves that we've been referring to, and how do they fit into the paradigm of treatment for severe or sometimes end-stage lung disease. When, as pulmonologists, we often use the term COPD, but really COPD comes in two different categories. There's chronic bronchitis, and then there's emphysema. Chronic bronchitis has to do with excessive amount of mucus production, and that disease affects the bronchioles. Emphysema, on the other hand, is a slightly different disorder that really affects the tissue integrity, and it causes destruction of the little air sacs called alveoli where the gas exchange is occurring. And as a result, patients become short of breath, not necessarily because they are producing excessive amount of mucus, but simply because they lose the surface area where their oxygen exchange is occurring, and they're not able to perform those important functions that the lung performs. And as a result of progressive destruction of these air sacs, air has trouble getting out. In other words, one of the important functions that lungs perform is they help us exhale. So when emphysema becomes severe, there is excessive amount of air that gets trapped, and we call that hyperinflation. And these are just some of the definitions that differentiate chronic bronchitis, which is an inflammatory disorder of the bronchioles, from emphysema, where the air sacs get damaged. These are just some of the interesting pictures that help you understand the difference between a healthy lung and emphysematous lung. And think of a healthy lung as a sponge, where there are many little air sacs where gas exchange is occurring. And on the right side of the picture, you see that these air sacs have coalesced into large sacs, and as a result, you lose a lot of the surface area where gas is occurring, causing low oxygen levels. Now, as part of my practice, unrelated to this talk, we perform a bronchoscopy where we use a robotic catheter to sort of look deep in the lung, and this has really allowed us to see emphysema that we've always talked about, but now for the first time we're able to see visually what emphysema looks like. And you see these strands or remnants of what used to be healthy lung tissue that have now really been replaced by what looks like obviously destroyed tissue. So this is what emphysema looks like on the inside. Now, we briefly mentioned the concept of hyperinflation. Again, that has to do with the inability of lungs to exhale air and excessive amount of air that's trapped in the lung. What that causes actually is that causes breathlessness on an account, not just because the lung function is bad, but also because the diaphragm has now become flat. In other words, the diaphragm is supposed to be dome-shaped, and again, the diaphragm is this major muscle. It's the most important muscle that is responsible for breathing. It separates the chest from the abdomen. Well, when you have too much air, the muscle becomes flat. The ribs are actually hyperexpanded. So those patients are at a mechanical disadvantage, and this becomes a mechanical problem when we think about hyperinflation. And then you get into this vicious cycle of breathlessness, followed by deconditioning, followed by more breathlessness. And you could it's easy to see how the patient can really spiral out of control as a result of severe emphysema. One of the ways in which we assess lung function is with a pulmonary function test. Many of you are familiar with that test. You blow into a tube and we measure lung volumes. Just to go into some of the granular details a little bit, because I think it does help patients understand what their doctors are ordering and why they're ordering certain tests. A basic pulmonary function test consists of three parts. There is spirometry, which measures how much air you can exhale. There is a measurement of lung volumes. And then there's something called diffusion capacity. Diffusion capacity just has to do with how well oxygen travels through the lungs, and it is an indirect marker of lung destruction. Lung volumes is a very important and a very relevant measurement to the rest of the talk, because this is how we can determine whether you may potentially be a candidate for some type of a lung volume reducing procedure. Obviously, lung volumes have to be elevated in order for a patient to qualify. And there are different ways in which volumes can be measured. And on this picture, you could see that a subject is sitting inside a confined box with a door, and we call that a body box or a body plethysmography. And this actually represents the most accurate way to measure lung volumes. Now, there are several other techniques that can be used where you're not sitting in the box, and those are usually acceptable for clinical practice in terms of managing COPD and inhalers, but really for the purpose of lung volume reduction evaluation, these tests, we really need them to be done in a body box to get the best values. And this is what we look for when we get the report, or the pulmonary function test report. It's going to be broken up into these three categories. And again, the numbers that are most relevant for determining whether someone has severe emphysema is something called FEV1, which is how much air you exhale in 1 second. And that number is typically going to be low, less than 50%. That would suggest a moderate or severe impairment in the ability to exhale. And then those lung volumes that we just looked at are represented primarily by something called RV, which is circled. That stands for residual volume. Basically, that means that how much air is left in your lungs after you exhale as much as you possibly can. We know that lungs never empty to zero, because then they would implode. So there's always some volume left, and this is the marker for that hyperinflation, that phenomena that we talked about, where the diaphragm is pushed down and the ribs are hyperexpanded. This is what makes patients short of breath, and this is the number that we are trying to target when we talk about lung volume reduction. Like anything else, there is a continuum, and we break things up into stage to help us better understand the different degrees of lung impairment. And when we talk about COPD, we talk about stage 1 through 4, 4 being the most severe, 1 being mild. And intuitively, as the FEV1 decreases, you essentially go up in stage. And this is a stepwise model where your pulmonologist is adding various inhalers or combination inhalers as you sort of progress across this algorithm. But one thing that I wanted to highlight, which is very relevant for today, is pulmonary rehab. What is pulmonary rehab, and where does it fit? And you could see that on this slide, pulmonary rehab is recommended whenever you hit stage 2 or low. So it is actually recommended pretty early on. It's up there with all of the medications that we use, and I think it's an incredible resource And we're lucky to be able to have a resource like this, where patients have an option of enrolling in this structured program. Again, pulmonary rehab has been shown to be extremely important in the management of emphysema, not just in end stage, but really early on, and the earlier the better. Now, when we move across the slide and we get to stage 4, which is very severe, this is where we talk about addition of long-term oxygen therapy, and the slide says consider surgical treatments. Well, what we're going to talk about today is going to be partially surgical, partially endoscopic or minimally invasive. Lung transplant also comes up at stage 4. So this is where we really have to look beyond medical therapy to help our patients. So the goals of lung volume reduction is to reduce this extra air that's built up in the lung, the hyperinflation. That is supposed to improve the mechanical disadvantage, get the muscles stronger, and help patients breathe better. And it has also been shown that part of the reason why patients feel better after a successful procedure is because you're able to shut down a particular area of the lung that is non-functional, and thereby allow other areas of the lung to expand and to work better, and to perhaps even divert some of the blood flow away from the quote-unquote bad area of the lung towards other areas. So we have demonstrated through research that there is redistribution of blood flow, there is improvement in the mechanical advantage, and those are just some of the reasons why these patients feel better. I wanted to show a chest X-ray on one of my patients from some time ago now, after a successful endoscopic lung volume reduction procedure, where we were able to shut down the left upper lobe. So the top portion of the left lung was closed using valves, and you could see that compared to the left side of the screen and the right side of the screen, first of all, what you're seeing on the left side is the bottom portion of the left lung, which in this patient was relatively healthy. So she's now using more of the healthy lung. The destroyed lung has been shut down. And remarkably, the diaphragm, which is that muscle that we talked about, that diaphragm went up almost 9 centimeters. That's a significant improvement in this patient's hyperinflation. So this is what we are trying to see in all of our patients, hopefully, but at least in some. And as I just mentioned earlier, we have scanners that can measure and detect blood flow. Blood flow is represented by this orange glow. And you could see that after a successful left-sided procedure, there is now better blood flow to the left lung, but even to after this patient had a right-sided procedure, the top of the right lung was shut down, and you could see that there was much blood flow to the bottom of the right lung, and then after you see a significant improvement in the blood flow to the bottom of the right lung. So we'll go over valves, which are endoscopic devices that get implanted using a small camera without any surgery. These valves have a one-way mechanism that allows them to ventilate, so air can exit but not re-enter. So if you could imagine that air is only flowing in one direction, it's only exiting but not going back in, and over time, now you could understand how a certain portion of the lung where these are inserted is able to close down. So this is just a schematic of how a valve has a little duct bill that opens and closes, allowing air to only exit but not re-enter. So who are the candidates for valves? These are obviously patients with severe emphysema who have symptoms, patients who are on proper medical treatment. The amount of air they can exhale is under 45% predicted, and the amount of air that's trapped in their lung is at least 150 or maybe even higher. So severe amount of air that's trapped in the lung. These patients at the same time cannot be too sick, right? So it's really the challenge in this is finding the right patient, because unfortunately many patients when they develop this severe degree of emphysema, they accumulate other comorbid conditions. They may sometimes be too sick for a procedure to be performed safely. So we check for all of that. And there is a caveat to a successful procedure if you're using valves, and that is that there should be no communication of air between the area of the lung that's being treated and other areas of the lung. And conceptually, you can understand that if you're trying to shut down a particular area of the lung and you have air that's flowing from other parts of the lung into the one you're trying to shut down, you will not be able to successfully close the lobe. So when we talk about fissures, we are talking about physical boundaries and separations between different parts of the lung. We have 3 lobes or sections on the right, we have 2 on the left, and so therefore you have only 1 fissure on the left and you have 2 on the right. And so when we are looking for a target of where can we put valves, one of the important things is that we look at fissures. And we have to make sure that these fissures are intact. And I can tell you that one of the most common reasons why patients get excluded from a procedure like this is because they don't have a complete intact fissure. And unfortunately, there is really nothing we can do about it. It's an anatomy problem, but that is unfortunately a prerequisite. So one of the ways in which we can further evaluate a fissure besides a CAT scan is that during the actual procedure, during the bronchoscopy, before we place valves, at my institution and my program, we routinely perform this little additional step where we have an opportunity to enter the area of interest, inflate a balloon so that air cannot flow into that part of the lung, and we can measure flow with the balloon being inflated. Now, if that flow disappears, that means that the fissure is intact. There's no communication. There's no other feeders of air into the area which has been closed. On the other hand, as you can see on the right side of the screen, if there is no disappearance of flow, if there's persistent flow, despite the balloon fully occluding the area of interest, well, then that means that air is getting through the fissure, and that fissure is therefore interrupted, and we cannot place valves. We routinely get CAT scans with a particular protocol, and unfortunately, not every facility performs CAT scans in the way that we need them to be performed. So sometimes your doctor may ask you to repeat a CAT scan for that reason, but basically a high definition, high resolution CAT scan gets submitted to the company. The company returns this type of a report. I call it anatomy scan, but basically what this is that this is a visual representation of your anatomy, of your lungs based on the CAT scan. But it provides us a lot of important information. The first piece of information is that it tells us how bad is emphysema. It quantifies it so that we can assign a number. The more emphysema you have, the darker the color, the less you have, the whiter the color. And so you could see that this individual has quite a bit of emphysema in the top of the lung and not so much at the bottom. This also gives us a sense of that fissure completeness. It gives us a percentage. And finally, it gives us the amount of volume that is sitting in each section of the lung. So this report is what we look at in order to better understand which patient is a candidate for the procedure. So what happens during the procedure, and more importantly after the procedure? What can you expect as a patient? Well, the procedure is performed under general anesthesia. So everyone who comes in for this procedure will be under general anesthesia. Now, this is a bronchoscopy, meaning that we go in with a small camera. We are not doing surgery. We're not performing any cutting or dissection. As I showed you earlier, we check for the fissure with a balloon before we place valves.
If the valves are placed, we get a chest x-ray after the procedure, and then the patients have to stay in the hospital for at least 4 days for observation. And the reason why we keep patients in the hospital is because we want to make sure that if they have a successful outcome and we are successful in closing a particular lobe, well, then some patients may develop called a pneumothorax, meaning that some air can leak out of the lung as a result of volume shifts. And if that happens, then we need to most often put in a small tube to evacuate the air. So we need the patient we need to be close to the patient if that were to happen. Now, luckily, if that happens, it usually happens in the first 2 days or 3 days. So that's where the 4-day mark came from. Once you're out of those first couple of days, it's much less likely for this to occur. This is just a visual representation of how some of these valves are deployed. This is, again, all done through a small camera. and as you can see that here, this is one of the valves. There are 2 types of valves that are approved in this country. And so here you can see that there is an opening and a closing of the ductbill that allows air to exit but not re-enter. Here's another example of a valve that looks a little different. Like I said before, there are 2 different companies that we use, and they really work in the same way. And this is a series of chest X-rays taken during those 3 or 4 days that the patient's in the hospital. As you could see, the valves were placed in the bottom of the left lung, and then that left lung really shuts down. The left upper portion of the lung, shuts down, and then the lower portion of the lung now opens up and takes up the space that was previously occupied by the upper. And you could see those valves on the chest X-rays you could see here. We talked about the most common complication being a pneumothorax, which means that some air can leak out of the lung, and that can happen in 30% of patients. Most of them happen in the first 3 days. So 1 out of 3 patients develop this phenomena. We are certainly cognizant of this. We are prepared for this, and we have many protocols in place to take care of this if this happens. One of the nice things is that the company provides us these little bracelets that we give to our patients, and when you get discharged from the hospital, if you develop any chest pain, shortness of breath, anything that seems unusual, and you go in to get a chest X-ray, you should always sort of have this alert on your hand that allows others to recognize that you're at a high risk of pneumothorax. Some patients ask more specifically, what improvements can I anticipate after a procedure like this? And again, everyone is highly variable because there are many different components and variables that will affect your outcome. But at least based on many clinical trials, we can say that there is a 17% improvement in the FEV1, which is how much air you exhale in 1 second, about a liter reduction in the amount of volume that's trapped, and about a 40-minute improvement in a 6-minute walk test. But the bottom line is that everyone is going to respond differently. And one of the most important predictors of how an individual will respond is their anatomy. So on the top of the screen, you can see that a patient has a distribution of emphysema where there is a lot of emphysema at the top of the lung, but the bottom of the lungs are relatively healthy. Well, these are cases because we know that these patients do very well because you can shut down the area at the top of the lung and allow that healthy lung to expand. On the other hand, we often have patients like the one on the bottom where, although there is still more emphysema at the top, but you could see that there's really no healthy portion of the lung left. Everything is emphysematous, something we call homogeneous emphysema that sort of all over the place and equally distributed. And unfortunately, as you may imagine, the response may not be as robust, although valves are still approved for that indication as well. So we've spoken quite a lot about valves, but what about lung volume reduction surgery? Well, historically, lung volume reduction surgery has been around for many years before valves were invented. And I think the surgery is still an important component of any lung volume reduction program because, like as I mentioned earlier in the talk, there are many reasons why an individual may not be a candidate for valves, including anatomical considerations with complete fissures. So sometimes we know that patient will benefit from lung volume reduction, but unfortunately, we cannot place valves. Now, lung volume reduction surgery is limited to a much smaller group of patients. It is really those who have most of their disease in the top portion of the lung with a nice differential distribution of emphysema between the top and the bottom. So it's really the patient at the top of the screen that would be potential candidate for this procedure. During this procedure, the portion of the emphysema at the top of the lung gets removed surgically. So conceptually, it is a similar process, similar procedure to valves, where we shut down a lobe, except here it happens surgically. These are just some of the differences between the two technologies. Obviously, bronchoscopy is non-surgical. It is also reversible, right? So valves can be removed. For example, if they don't work or if the patient does not derive the benefit that we think they'll derive, we can always pull the valves out. Surgery is irreversible. There is a much broader group of patients that's a candidate for valve procedure compared to surgery, because we know that valves can be placed anywhere. It depends on the initial investigation. However, on the other hand, there is a caveat for presence of fissures, which we don't have that requirement for surgical lung volume reduction. These are just some of the representative pictures of what lungs look like when the surgeon puts in a camera, and this essentially are large bulla, which are these enormous air sacs that once used to be healthy lung, that are obviously non-functional, but they take up space and they compress. As you can see here on the bottom, there's normal lung that's being compressed by these bulla, and then the surgeon is going to staple the bulla off to remove them to allow the lung to re-expand. And this is actually from one of our patients from some time ago, where she left a very nice message on Facebook, where she talks about her experience and her outcomes after a successful procedure. Again, I do have to say that results are very highly variable, okay? And it really depends on your anatomy, but certainly we have all seen a fair number of patients who came through and had a really nice benefit. And again, going back a little bit to pulmonary rehab, many of those patients were able to re-enroll into their rehab programs because now they can breathe better, they can derive a lot more compared to before. So this is all I have. And again, I want to thank everyone for the invitation. And then if questions, I'll be happy to answer them. Thank you.
Great. Thank you, Dr. Shostak. That was a great presentation. We do have some questions from the audience. And one of the things that I want to mention is that I'm a general pulmonologist. Dr. Shostak, besides being a general pulmonologist, also an interventional pulmonologist. So if it's something that you have a question, are you a candidate, you would generally go to your general pulmonologist, and then they would refer you on to an interventional pulmonologist to kind of get this evaluated. And so the question I have is, you mentioned as far as who's a good candidate, but also walk us through the time period from when someone's referred to you to actually getting a valve. Let's say they are a candidate. I know there's some cardiac workup. I know there's some CAT scans and things. What does that time period look like? Is it a week, 2 weeks? Is it a month? What would you say?
Yeah, no, that's a good question. That time period could be. It really depends on some of it is logistics and some of it is patient driven. So from our standpoint, as we looked at one of the slides, there are sort of a couple of core tests that need to be performed routine on everyone, and obviously if there are some special circumstances, then there may need to be more. But at the core of a proper workup, we will need to make sure that there's a CAT scan that can be used to generate that anatomy scan. We will need to make sure that there is a pulmonary function test performed in that body box or body plethysmography. We need to make sure that there is a perfusion scan that measures blood flow, and something called the blood gas, where we check your blood for carbon dioxide, just to make sure that there's not too much carbon dioxide dissolved in your blood. And again, this is one of the safeguards for undergoing general anesthesia. Now, in my program, I'm in New York City at New York Presbyterian Cornell. So in my program, we're used to seeing patients that come to us from areas that are far away. And so we're very cognizant of that. And we have developed a workflow that allows us to bring the patient in and perform all the testing in one session. It may take a little bit of time to coordinate all of those tests, but potentially a patient can walk in, spend half a day getting all their tests done. Sometimes I see them the same day. Sometimes we do a video visit before. But potentially, all of this could be done in one session, and then we wait for about 2 weeks to get the results of that anatomy scan, and by that time we have all of the tests back. So the time frame could be as short as 2 weeks, and obviously this can also stretch out for many weeks on the patient. Now, we also have this is not unique to us, but other programs have this as well, where there is a multidisciplinary team that meets to discuss all the patients, because these are obviously complicated cases and there may be more than one answer. And so we have that opportunity to meet once a month. So all of the patients from that month get discussed at a conference. So I typically will not provide a definitive answer or a recommendation until after the conference meets, which is once a month.
Okay, thank you. That's very, very, very good. So the other question I have is, since a lot of the interventionalists that are doing this, just as yourself, are in larger centers, what's the follow-up then? Once they get the valve, they're in the hospital 4 days, 5 days. They don't have any complications, no pneumothorax. They go home. Now what's the follow-up?
Yeah. So the primary pulmonologist always remains their main go-to person if there are questions, if there is an issue. Again, this just has to do with geography. From our standpoint, and again, different institutions do this a little differently, but the way my workflow works is that 2 weeks after discharge, we usually meet again, whether virtually or in person, depending on where the patient is from, with a chest X-ray. Because by that time, we want to be able to get a rough sense of how things are going and how the X-ray looks, and hopefully we see some degree of atelectasis, which is deflation or closure of the area that was treated. Beyond that, usually about 6 weeks, which is day 45, and that's what the clinical trials have been designed. We meet again with a CAT scan, because usually by day 45, after the procedure, we expect to see some degree of effect. And if we don't see anything on day 45, then the other important question, of course, is how are you feeling? Because that's more important than an X-ray. And I've had a couple of patients that had a discrepancy between the way their CAT scan looks and the way they felt great. and the CAT scan looks absolutely the same as before. And we typically do a lung function test around day 45 or a little later. So we see them back at that visit, and we have some objective data between their lung function and their CAT scan. We get a sense of how they're progressing. And then, depending on how things look, if they don't feel better and the CAT scan doesn't look any different, then we may talk about potentially going back in and trying to understand maybe one of the valves is not sitting well and revising one of them, and that would be a discussion. Alternatively, if they're feeling better, then that matters the most, and then we would probably see each other again in 3 months' time, and a couple of times thereafter throughout the year.
Okay, thank you. You mentioned there's two valves, and is there any difference between those valves? Is there have you experienced any allergies as far as material of those valves? Can you kind of go through the valves?
Yeah, that's a good question. So there are two companies that both have approval, FDA approval. One is the Pulmonary company that makes the Zephyr valve, and the Zephyr valve is the one valve that opens and closes. The other valve is the spiration valve made by a company called Olympus that has that little umbrella device with the little hooks that bite into the bronchi that sort of hold it in place. So they have different designs. Visually, they look very different. Conceptually, or mechanistically, they are the same. There has never been any studies comparing the valves head to head, and I don't think there will be. And I think that it is really, to some degree, a dealer's choice or a preference of an operator as to which one they use. Now, in my practice, I use both. Very often, I would insert both in the same setting because there may be some technical differences. But one cannot say that one's better than the other. As far as allergies go, they both are made out of nickel, or they have nickel-containing material, rather. And so if someone has nickel allergy, then this would be contraindicated if it's a true nickel allergy.
Okay, thank you. Does one have to change their lifestyle in any way as a result of the valves, or can they just, afterwards go on doing their daily routine, or what would you recommend?
Yeah, so the valves are fully MRI. I guess the word is conditional. Say conditional, so not but basically you could get an MRI with the valves. They don't set off metal detectors in airports. There is really no change in lifestyle that is required. In other words, if someone uses CPAP for sleep apnea, they can continue using that. If someone uses a percussion vest for phlegm expectoration, they can continue using all of those things. You will not dislodge the valve by any type of flutter device or vest or positive pressure. And so there is no change in your routine, and hopefully if the valves work, the routine will get better. But other than that, there is no special precautions.
Great, great answer. So what any other, can they continue their inhalers? Can they continue their rehab? Can they kind of continue basically whatever they're doing beforehand? They really don't need to change anything afterwards. It's basically what you're saying.
Right. That's exactly right. Inhalers, I would say, the goal of the procedure is not to get them off inhalers. The goal of the procedure is not to get them out of rehab. In fact, it's to get them into rehab, because hopefully they can feel better, they can get more out of rehab. And what we hope to do, of course, is to decrease their oxygen requirements. So that is one of the goals of the procedure, and that has been successfully done, particularly in patients with favorable anatomy.
Okay, and the other question I have is, any cardiac evaluation? Is there any preclusion for cardiac patients?
So patients have to be able to undergo general anesthesia. So anyone who's too sick for general anesthesia or a bronchoscopy in general, unfortunately, cannot have this procedure done. Okay. And so anyone with unstable cardiac issues, we always get an echocardiogram, make sure they don't have severe pulmonary hypertension, make sure they're not in heart failure. So unfortunately, like as I mentioned before, these patients are already very compromised from the pulmonary standpoint, and sometimes they do get excluded.
And if somebody gets the valves, if they have to be removed, is there any downside to that? Meaning, does it worsen their lung function from having them and then not working and then having to take it out?
No, it doesn't worsen the lung function, but of course it does subject them to another procedure. And so that is the one important caveat that we always talk about with our patients, is that this is not surgery. This is a foreign body that gets implanted, and like any other foreign bodies, it can occasionally move. There's no absolute guarantee that a valve is not going to move. I mean, it's rare, but it can happen potentially. And if it happens, then that may lead to a loss of a benefit. And so patients do need to understand that there is a potential for having more than one bronchoscopy that needs to be performed.
And if one gets the valves, does the effect wane over time? I imagine tissue will grow over it. Would you need the procedure again, or once a lifetime is basically enough?
Yeah, the valves are really meant for life. Although they could be removed, they're not really designed to be removed unless they're not working. But we've now had our program for a couple of years, and now I'm starting to see some patients who did extremely well about 2 or 3 years ago that are now coming back with more shortness of breath. And those valves are perfectly positioned, and their CAT scans and X-rays look exactly like they should be. Unfortunately, they have disease progression on the other side. And so of course, valves don't protect you from having more emphysema that develops a couple of years down the road. So that's number one. Number two, there's been some interest in treating the other side with valves. That certainly has not been the way in which the valves were studied, or the way in which they were FDA approved. So in the United States, this has only been approved for one side and one side only. Now, that being said, in Europe and even on case-by-case basis here in the States, some practitioners have been treating both sides. That's not something that anyone can promote. That is truly on a select case-by-case basis. But the short answer to the question is that yes, unfortunately, over the years, the symptoms may get worse from other areas progressing. Great,
thank you. And I know you mentioned FEV1 of improvement in 17%, 6-minute walk improvement, 40 meters. Kind of put that into context for a lay person who's not sure what that means. What success rates are you seeing? In other words, people are always asking me, what is the success of the valves? And so just kind of in layman's terms, what does that mean to you and to your patients?
Right, that's a great question, and I agree with you. Those numbers are meaningless. Those numbers were derived from clinical trials where you need to, as I say, put a finger on the result and be able to report something objective. What it really means for a patient is, well, first of all, it's going to mean different things for different patients. But what I've learned over the years from my patients is that I've sort of gotten a better appreciation of what their life is like, and things that we take for granted, such as our normal routines, ability to breathe, ability to perform our daily activities. Many of these patients have lost that ability because of severe emphysema. And so 40-minute improvement in their walk or 17% improvement in their lung function could be a difference between being in a chair and being sedentary versus being able to walk around your apartment, which to us is not a significant difference, but to someone else who has really been not able to perform those simple activities, that could be monumental. Or in someone else's case, it may mean ability to go out shopping or walk up a few flights of stairs. So it's going to mean different things for different people. Or, for example, getting off oxygen, which is a big one. And that's what it's all about. And I think looking at the intrinsic anatomy, as we did, as I showed you on the prior slides, and having that sense of predicting how an individual will respond, I think that's an important skill that comes with experience. And I think that at least in my practice, I will provide my honest answer to the patient that, look, I think that you will have a great outcome, or the outcome may be marginal at best. And I think that's something we can now predict.
Okay, very good. You mentioned pneumothorax as the main complication. What other complications are you seeing, and would you see them very quickly, right away, within those few days in the hospital, or do you also see some complications, maybe weeks later or maybe even months later?
Yeah, well, the other complication that often comes up as a question is pneumonia, because one may think that because you're putting in devices, maybe secretions can't ventilate, and maybe patients will develop pneumonia. So what's interesting is that pneumonia is actually very uncommon. In clinical trials, it's about 10%. It could happen, but it's rare. The reason why it's rare is because valves have an ability to ventilate secretions. They're not plugs that just plug up an area of the lung. So yes, pneumonia can happen. It's rare. What's not uncommon is simply seeing an exacerbation of COPD right after the procedure. That's something that we are very well tuned into. We can manage it and take care of it with medications. So that is something else that gets seen. Now, remember, when we select patients, we have the safety guard, so to speak, where we will not offer a procedure. We will not bring someone in for this procedure if we think they're too sick. So we really don't see a whole lot of respiratory failure. Scary things like bleeding or even death is really uncommon as long as we continue to follow guidelines in selecting the right patients.
Are there any patients that you would maybe place valves knowing or not knowing that they may be a transplant case later on, meaning as a kind of a bridge? Is that a possibility, or not so?
That often comes up, and that is definitely a possibility. They are not mutually exclusive, and patients are often on the wait list for many years. So we occasionally do see younger patients who are either candidates or maybe just undergoing their transplant evaluation. So this is definitely something that could be used as a bridge, for sure.
Okay. The other question is, let's say you get lung valves placed, let's just say in the right upper lobe. A few years later, you're experiencing more shortness of breath. Is that a candidate for more lung valves if potentially they are having emphysema in those areas?
Yeah, so as I mentioned before, now we're starting to see more patients who are coming back to us with really where their volumes revert back to what they were before a few years prior, but their valves are perfectly well positioned. There may be an opportunity for treating the other side on a case by case basis. Definitely not the way in which the trials were conducted. So that would be the answer. And theoretically, if their anatomy is not conducive for the other side to be treated with a valve procedure, maybe they may also be candidates for lung volume reduction surgery on the other side. So that is, again, case by case basis.
Okay, very good, very good. Well, I want to thank you, Dr. Shostak. This was really enlightening. I think a lot of our audience, I'm really glad that we presented this. people come to me all the time with these questions, with these issues of lung valves, and I think you've answered a lot of the questions very well. And I want to thank you so much for being with us and helping us and talking to our patients. Thank you so much.
The only other thing I'll add is that this is also this topic is one of the very few examples, if not the only example that I could think of in medicine where, because this is a relatively new technology, patients are often their own advocates when it comes to this to this particular procedure, and very often patients they will go online, they'll read about this. There's also a website that lists all the centers in the country that offer this procedure. It's on the Pulmonary website, and so I always sort of want to encourage patients to read, to ask the right questions. Very often, as doctors, we learn from our patients a lot, and I've certainly learned a lot from my patients in this. But patients do have resources that for them specifically designed, where they can have an opportunity to seek an evaluation or even get an opinion from a center that performs these. So I think it's just something that patients should always remember, because it is a relatively new technology, and not everyone is as familiar with it as others. So just as a reminder for the patients to sort of continue being their own advocates.
Great, thank you so much. Thank you for being with us.
Have a good night.
Thank you. You too.